The February issue of the Journal of Vascular Surgery has many articles which should be of interest to you, and I'd like to mention just a few. The Editor's Choice article, Risk Stratification for the Development of Respiratory Adverse Events Following Vascular Surgery, using the Society of Vascular Surgery's Vascular Quality Initiative, by JVS and co-authors from the University of Pittsburgh, used the VQI database to investigate postoperative respiratory adverse events in patients undergoing both endovascular and open vascular surgery procedures. They found that 5% of the 52,000 patients who had vascular procedures developed postoperative respiratory adverse events, defined as pneumonia or the need for reintubation. Risk factors, which are shown in this table, were current smoking, recent myocardial infarction, symptomatic congestive heart failure, chronic obstructive pulmonary disease requiring oxygen, urgent and emergent procedures, open abdominal aortic aneurysm repairs, in situ suprainguinal bypasses, and thoracic endovascular aortic repairs. Those with respiratory adverse events, shown in this figure, had significantly higher rates of hospital mortality, increased length of stay, and were more often discharged to a nursing facility. The implications of the study are that awareness of risk factors for postoperative respiratory adverse events should be used in preoperative counseling, in selecting the best procedure, and in postoperative management. The next article, by Starnes from the University of Washington, reports on the midterm results from a physician-sponsored investigational device exemption clinical trial evaluating physician-modified endografts for the treatment of juxtarenal aortic aneurysms. They report on 60 patients who were deemed unacceptable for open surgery and therefore were treated with physician-modified endografts. The results are remarkable, as shown in this table, with a 5% mortality, no endo leaks, a short procedure time, and no conversions to open repair. The authors emphasize that the key is preoperative planning, but that an experienced team can achieve results that are equal to or better than open repair for juxtarenal aneurysms in normal risk patients. Another paper, Risk Factors for 30-Day Unplanned Readmission Following Infrainguinal Endovascular Interventions, by Baduas and authors from the US and Europe, addresses readmission after endovascular procedures for PAD. They use a large database, NISQIP, and evaluated readmissions over a 2-year period. There were 4,449 patients who underwent infrainguinal endovascular intervention, of whom 63% had critical limb ischemia and 30% had claudication. The unplanned readmission rates shown in this table for CLI and claudication patients were 16 and 6.5% respectively. Mortality after index admission was higher for readmitted patients compared with those not readmitted. Approximately 50% of all unplanned readmissions were related to the index procedure. Among CLI patients, the most common indication for readmission was wound or infection related, whereas patients with claudication were mainly readmitted for recurrent symptoms of PAD. In patients with CLI, predictors of unplanned readmission, shown in table and sections A and B, included diabetes, congestive heart failure, renal insufficiency, preoperative dialysis, tibial angioplasty and stenting, in-hospital bleeding, and in-hospital unplanned return to the operating room, as well as discharge other than to the home. Risk factors for those with claudication were dependent functional status, smoking, diabetes, preoperative dialysis, procedure time exceeding 120 minutes, in-hospital bleeding, and unplanned return to the operating room. Awareness of these risk factors will help surgeons identify high-risk patients who may benefit from preventative measures to decrease postoperative complications and readmissions. The last paper that we're making available to all readers is from Queensland, Australia by Candy et al., entitled Paclitaxel Coated Balloon Reduces Target Lesion Revascularization Compared to Standard Balloon Angioplasty. The authors performed a meta-analysis of all available literature that compared the outcome of patients treated with drug-eluting balloons and compared them to percutaneous transluminal balloon angioplasty, measuring the rate of target lesion revascularization. They found 10 articles with 1,292 patients, as shown in this figure, and pooled the data on rates of target lesion revascularization, restenosis, and late lumen loss. The rate of TLR in drug-eluting balloon-treated patients was significantly lower, as shown in this table, compared to patients treated with PTA at 6, 12, and at 24 months, as shown in this last table. This meta-analysis demonstrated that drug-eluting balloons compared to PTA result in reduced rates of reintervention in patients with PAD. Please read these articles as well as the many other excellent articles, editorials, and special features in all 3 JVS journals, and thank you for your attention.